Well, hello everyone, and welcome to the Heartland Daily podcast, where once again we're going to be talking about news developments in the healthcare sphere, as we do a couple of times each month. My name is Anne Marie Schieber. I'm the managing editor of Healthcare News, and joining me is Devin Herrick. Devin is a healthcare economist who writes and posts on the Goodman Health and Research Institute's healthcare blog. Writes a lot of good stuff. He joins me every week, and we talk about, oh my goodness, so many things going on in healthcare. How you doing, Devin? You
I'm
enjoying the
doing
summer?
well.
It's not a quiet summer, is it? As far as what's going on in turn, for
Well, we're
healthcare
getting a lot of
bills.
rain.
Well, that's true too. That's been dominating the news in various parts of the country. And I know you're in Texas, and they had that terrible rainstorm, 4th of July, and we're all thinking and praying for those families. Just very sad. Um, but we carry on. And, I was thinking about it because on 4th of July, we had another big thing that was sort of overshadowed, which we had been talking about for, of course, many, many months. That's the One Big Beautiful Bill that President Trump signed on July 4th, like he said he would do. The House and Senate agreed on a final bill and sent it to him for quick signature. And I know a lot of people were kind of disappointed, but my goodness, there aren't huge majorities of either party in both chambers. So it's not a surprise to me that we got what we did. There was a real interesting article that came up in Unleash Prosperity today, the Committee to Unleash Prosperity. If you can go down to item number 3. So people who were disappointed that healthcare, there couldn't be more cuts, more reforms. This was an interesting item. It was an interview that House Budget Chairman Jody Arrington did with Bloomberg News. And I don't have Bloomberg up there because it's paywalled. But he made this comment, which I thought was interesting. He said, on the agenda, they're going to start now pushing some of these reforms through the margins. And it's going to be interesting. The idea with a reconciliation bill was that it couldn't be filibustered in the Senate. But a problem that took a month to get through the Senate because of questions about what was usable in a reconciliation bill and lots of debate about that. And so they had to water down a lot of things. But this was interesting, I thought, that Arlington said, and if it happens, I know there's a bill out there. One of the things they want to eliminate or to create are site neutral payments. That is the practice of paying hospitals the same price as everybody else for procedures in Medicare. Hospitals get an extra payment to cover their expenses, and it's driving up healthcare costs. And we can talk a little bit about that. The other thing he mentions in this, and then I want to throw it to you, Devin, to get your thoughts, the reimbursement rates. So that was another big disappointment. We have expanded Medicaid in, I think, 6/8 of the country. I don't know. I think there's like Texas, a holdout state, maybe 5 states don't do expanded Medicaid. But the reimbursement rate for expanded Medicare is 90%. And they reduced it to 80% in the bill, the big, beautiful bill, to states who are extended care, Medicaid states who do not enforce illegal immigration in Medicaid. Now, that's going to be real interesting because I think that's going to continue. I don't think these states are just going to say, okay, we're not going to provide Medicaid to all the people here illegally. But they can do that. And that is a huge chunk of change for states to have to come up with if they have to pay that out of their own pocket. So let me go back, Devin, and ask you what you think about the possibility that there will be a bill that will become law that will mandate that hospitals be paid the same as everybody else when they do things under Medicare.
Oh, the hospital lobby is very strong, unfortunately. But that really would be a great idea. And it's not just that hospitals get overpaid for things that we can get cheaper elsewhere. It's that hospitals are buying up physician practices left and right because they can charge higher fees. I mean, you go to your doctor, you've gone to the same doctor for, 5 years. All of a sudden, one day you go to your doctor and you get a bill and like, well, what's this? Oh, this is a facilities fee. We sold out to the hospital. We are now technically employees. And so now you have to pay, 100, 200, whatever it may be, additional just because the hospital owns that physician practice. Plus,
Right.
that physician may have incentives to order, to do the hospital's bidding. You're not the patient anymore. The hospital's employer, or the physician's employer may be the real client or real customer. So it is a big concern to me. And it's not
Yeah.
just what we've talked about in terms of getting paid too much for an MRI. It also includes whether your doctor really works for you or works for the hospital.
Well, right. And we end up all having to be filtered now through corporate medicine. There are no independent practices because they're gobbling up independent practices right and left. Medicare or, enrollees have to pay more for those expenses. So let's say they need an MRI and the only place they can go is to a hospital organization. They're going to pay top dollar for that. They got to pay a
Mhm.
copay on that, and it drives up their costs. And then it spreads to other people outside of Medicare, as you mentioned
Yeah.
earlier, about it having an impact on the healthcare marketplace. And so it's very difficult to find any competition that drives up costs. And I really am hopeful. We've talked about this for many, many years, but this idea of site neutral payments has
Mhm.
never gone anywhere. And maybe this time there'll be some momentum. What do you think about the Medicare reimbursement system or possibility of going down 10%, which is a huge chunk of change that states are going to have to come up with, that they're not going to get from it's 10%, the federal government's not going to pay them. They're going to have to cut corners.
Oh, that's an interesting incentive. It's like if you don't do things our way, we're going to stick it to you one way or the other. And I don't know how that will play out in the long term. Again, because physicians and hospitals and the like, and the Medicare reimbursement is already well below, what private insurers pay, but it's above what Medicaid tends to pay. So it'll be interesting to see how that plays out, whether
Well,
that will provide an incentive.
I don't mean to interrupt you, but in the big beautiful bill, there is a provision in there that mandates that Medicaid reimbursements to hospitals be lower than Medicare. They were paying
Mhm.
commercial rates. And of course, the hospitals love this because what, 1 in 5, maybe 1 in 3 in some states are Medicaid enrollees. And it brings in a ton of money to these hospitals. And, we're talking, eight, what is it, $8 trillion, $8 billion over 10 years that we're cutting from Medicaid. And the numbers are so astronomical, I kind of lose track of talking about, but
Yeah.
that would be a lot of money that the hospitals and insurance companies are not going to have. That's where that money goes. And I find it real interesting how all the scaremongering going on about Medicaid being cut and how people are going to be left on the street. I bet no one's going to notice because that money is not going to healthcare. It's going to pay for big hospital expansions and $10 million salaries for executives. And most people are not going to see the cuts as, the scaremongers are leading people to believe. So stay tuned, buckle your seatbelt because it's going to get really rocky here, I think, in the next couple of months. But Medicaid, as it is, the expanded Medicaid program is not sustainable. And it's socialized medicine, which is basically what Obamacare ended up being. And, we'll see. Let's hope we can get some of these reforms. We hope that some of these states will be incentivized to do some cost-cutting ways to deliver healthcare better. Everyone thinks if you cut something, it's going to be decrease in quality and quantity of healthcare, and that's not the case. It's just smarter ways of spending to deliver healthcare. I want to bring up the article, if we can, Andy. Michael Cannon wrote this a couple of weeks ago. It was right before the big bill, beautiful bill was delivered to the House again. And it's called Tom Tillis Defends a Medicaid Scam. Now, this was real interesting because he was the one Republican who did not vote on the big beautiful bill. And I think it got through by one vote. And what is there, like a 5-vote margin in the Senate now with Republicans? It did get through. But he wrote this article, and it was interesting why he sat this one out. And according to Michael Cannon, this is what goes on. So one of the things that the big beautiful bill talks a lot about is this thing called provision tax. Devin, you want to talk about that and explain how that works? Because it's kind of a racket.
Oh yeah, it's a scam. The way it generally works is that, well, first off, I should back up and say Medicaid is a federal state partnership with different pots of money for different categories of beneficiaries. It involves matching funds, and matching, for example, the matching funds for expansion populations would be different than, say, the matching fund for children or for adults and so forth. Well, what happened is, states are supposed to pay their share. And really, it's a pretty good deal for states. I don't have the exact figure in front of me, but for states like Alabama, up to 80% of the cost of their Medicaid is paid for by the federal government, and they only have to come up with, around 20%. On average, it's about 50-50, but it varies, like I said, depending on the state and depending on the category of beneficiary. Well, what states began to do years back is they would cut a deal with the healthcare providers, like, well, we'll pay you a little bit more than we otherwise would, but then we are going to tax you roughly equal to what we paid you additional. Then we're going to give that money back to you in the form of payment for Medicaid enrollees. And we're going to count that as part of our share of Medicaid spending for the purposes of getting federal matching funds. So it's a convoluted way to not really have to pay your fair share if you're a state that does that. And virtually all states do it in one way or another.
So in the big beautiful bill, they were charging these providers like 6% in tax. Then they would bill this to the federal government. It's called a Medicaid money laundering scheme. That's what some people call it. And then the states get that money back, and then they give that money, some of that money, back to the provider. They love it because they're getting more than they thought. And the states love it because it brings more money to fuel their economies, and they can spend that money on anything they want. And it's usually blue states that are the ones that are big users of this so-called provider tax. Under the big beautiful bill, it's going to be cut now to 3.5%, except in non-expansion states, which I thought was really good. So, there's another incentive there for states to get back to traditional Medicaid reimbursement. I think people are really surprised when they find out that the federal government reimburses states more money for able-bodied people than the traditional enrollees for Medicaid, the disabled, pregnant women, single women. And they're the ones who really suffer because they do not get the attention and the health care and the supply that the expansion population gets, because the expansion population brings in so much money. And it shouldn't be that way. I know there's a big push, and it couldn't happen under this big bill, but the idea is to get that reimbursement rate the same for everybody. In Texas, which is a non-expansion state, they're getting 65% for every dollar they spend on Medicaid, and they're losing out. And there are people who know that, and they're pressuring Texas to expand the program, but they don't want to do it.
Well, and it's also a case of, fairness for physicians. No physician really likes taking Medicaid, but many physicians feel they need to. They feel it's a moral obligation. But then we expand Medicaid from the poorest to, someone that's richer or someone that's not working or are much higher income, and doctors began to balk. It's like, wait a minute, I feel it's my responsibility to treat the poorest of the poor that are on Medicaid, but I don't want to have my practice to be people on Medicaid because I can't make a living. That's what they think. And, of course, the same is true of Medicare. I mean, Medicare, it still pays a lot better than Medicaid generally for physician services. But most physicians try to keep their practice to a ratio of Medicaid to Medicare to private pay. And when you expand Medicaid, you're putting pressure on that, where doctors begin to say, no, I can't accept Medicaid patients, or usually it means I can't accept new Medicaid patients. And so you find that you're paying for people to be on Medicaid who literally can't find the doctor.
Yeah. All right. I want to jump ahead to your article on work, on the work provision. So you wrote this a couple of days ago. Should work be a condition for Medicaid eligibility? Now, this is getting all kinds of heat from Democrats, from the left. They think this is the most draconian thing you could ever do to somebody, which is to tell them to value what they're getting from the federal government. Now, we've tried this before under Trump 1, and these provisions ended up in court. And many states dropped them. States were getting waivers to require their expansion population to work for Medicaid. And the requirement wasn't usually that big. It was like work 20 hours a week, a month. Or, you could go and enroll in a training program, but it was just something to occupy your time. Devin, can you talk about why it's so important to do this? It's not just because, people are trying to push jobs. There's another reason for it.
Well, it's very popular among Republicans especially. And support for the Medicaid program in general rises. And I think the New York Times wrote about this. Support among Republicans for the Medicaid program goes up if people have to work for it. And it's not just, it's from a standpoint of, it may not actually induce more people to work, but at the very least, it'll make people appreciate what they have. And it will probably weed out a lot of those that don't appreciate it. And one thing I've always said, I've never really read this, it just makes sense to me, is that most Medicaid nowadays is run by managed care organizations.
Mm-hmm.
They're going to get paid whether I see a doctor or not. And if I can't see a doctor, well, they're going to come out ahead. And so if I don't value that program, if I don't use that, if I don't need those benefits, we really shouldn't be paying for them to have those benefits, paying the private plans to not provide the care. So I think work requirements are really a straightforward, common sense approach to, if you want Medicaid benefits, you need to go online once a month or whatever, it'll vary by state probably, and just verify that you're working or looking for work or in a training program or disabled or whatever your criteria is. And I think that overall, states will probably have to experiment until they find the appropriate mix of requirements to be efficient as well and effective and not unduly burdensome, but where they actually work. But I think a lot of people, including Democrats, would agree that, if you're getting a benefit, if that benefit is costing taxpayers hundreds of dollars per month, there's no reason why you shouldn't go online and spend 5 or 10 minutes once a month verifying that you're in fact eligible for those benefits.
Well, it forces people to value the program. And if you get something completely free, you don't value it and you tend to waste it. And so to me, it seems like the biggest screamers about the Medicaid work provision are the insurance companies and the hospitals, because they're not going to get automatic payments now. What happened in Georgia was the only state that stuck with work requirements. Last year, they passed it. And when they did, I think Medicaid enrollment dropped precipitously. Like people
Mm.
didn't sign up for it. Either they couldn't be bothered or it's too much of a hassle, but they found healthcare some other way, or maybe they went without. I don't know. But, I think the hospitals are worried that people are going to go uncovered. And then, the people without health insurance get really sick. They go into the emergency room and there's nobody there to bill. And so states are really going to have to figure out a way to get people more engaged and find better ways to deliver healthcare instead of just wasting all that money. And the work requirement is not going to apply to people who are truly disabled. There are going to be all kinds of exceptions, and states are going to have to come up with those rules. They're going to have to figure out a way to manage it. And then, the federal government is going to have to do its diligence to make sure that states are following the provision in the law. So there's a lot at stake. We will see. It's not going into effect, I think, until next year. So we'll know how this does work out. All right, moving on. One of the things in the big, beautiful bill, and we've talked about this before, so I don't want to dwell too much on it, but there was an expansion of health savings accounts. I got to take a drink of water here. All right, these things, reformers love health savings accounts because it puts money directly into people's hands, and they can spend it directly on healthcare. We haven't expanded HSAs in many, many years, and they're very limited. The only people who could get an HSA were people in high deductible healthcare plans. Well, under the big, beautiful bill, they expanded it a little bit more so that I think 20 million people now will get HSA, 40 million will get HSAs as opposed to now 20 million. You can now use your HSA to pay for direct primary care. You still have to be in a high deductible plan, but the accounts were also, there was some discussion whether you could use your account to pay for gym membership. That was nixed in the Senate. What else? The tax gets over the tax benefit to the wealthy hurdle. Okay, so a lot of people were saying HSAs are really a tax benefit to wealthy people. That is very untrue because, first of all, the contribution amount isn't that big, right? It's like that hasn't changed at all. And, you have a huge tax benefit on it. You can take the money out tax-free. It can grow tax-free. You get a tax deduction for contributing to an HSA. But again, there's a lot of restrictions on these things that they're not going to be used for an investment tool per se. I think this just kind of opens the door on HSAs. They're a great idea. And I think, over time, maybe in the next reconciliation bill, we'll expand it to people without a high deductible healthcare plan. We can only hope. Any thoughts on that, Devin?
Oh, that would be great. Because what I ran into was, I have an HSA, I had a high deductible health plan, but then I switched to another one, like in 2023, I want to say. And I found out after the fact that my new health plan, which was high deductible, had a deductible that was actually too high to qualify for my HSA to make additional tax-free deposits. And the whole purpose of an HSA, one purpose is to save for future healthcare needs. Another purpose is to equalize the tax treatment of healthcare you buy through, say, a employer health plan with self-funded healthcare. If you buy healthcare through your employer, you're getting a huge discount. It's the taxes. But if you pay out of pocket, you're using after-tax funds. That's a big difference. The HSA allows, individuals to use pre-tax funds to pay for healthcare below their deductible, the same way that a employer plan allows their workers to buy healthcare at a, pre-tax, tax-free discount. And I think that's really a very important distinction. And it would make a lot of sense to to relax the rules to allow people. I mean, you could. I don't know what those would be, but why should I have to have a high deductible health plan? Maybe I would have a care and share type plan, or maybe I would have a short term plan. I mean, I'm still, I'm still going to use my HSA for healthcare. It doesn't matter what kind of other funding mechanism I have. So it would make sense to allow more flexibility.
Yeah. Well, I agree, and they're also allowing another kind of Obamacare plan to be HSA eligible, which is the bronze plan and the catastrophic plan. Which I think the catastrophic plan is very limited to who can open one. The bronze plan is the super high deductible plan. It's really for covering hospitalization. All those plans, to me, in my opinion, are way too expensive.
Mm-hmm.
I just would like, and the other unfair part of it is that they're really only available to people with employer healthcare insurance. And if you're a self-employed person, a gig worker, you don't have access to those rates. It's probably very cost prohibitive. You have to go on the Obamacare exchange to get healthcare if that's an option for you. So, I just hope that we would get to a traditional idea of being able to set aside money, no strings attached, in an account that can grow over time that people can use for healthcare expenses. I mean, imagine that. You could have that thing for a lifetime. When you get older and retire, you could have a pot of change ready for long-term care, which Medicare does not cover. And people end up having to do all kinds of tricks to get onto Medicaid, to get their long-term care paid for, and that's draining Medicaid. So I just think it's an overall good idea. We're stepping in the right direction, and it's just going to take time to unwind and get to some of these reforms. But I was glad to see that in there, but I think more can be done. Couple of decisions. I want to move on to a couple of things that happened in the Supreme Court impacting healthcare. Now, one was a case that's been going on for many years. I want to say since 2018, involving the case of South Carolina. South Carolina came in and they decided that they did not want Planned Parenthood as a Medicaid provider. Well, a beneficiary, an enrollee, sued South Carolina and said, no, you have to cover, this is my preferred provider, and you have to cover it. And so they sued the state, and it ended up in court, and it was in court for several years. It made its way to the Supreme Court, and the Supreme Court came down and said, you know what? States can have the right to pick and choose who they want to cover under Medicaid, and nobody has a right to sue them. You're not entitled to a particular provider. So this is going to be really impactful, I think, for Planned Parenthood, but I think it's just overall just interesting, I think, giving states more control over who will be included in their Medicaid provider list of, or a list of Medicaid providers. If you've got a clinic that's doing controversial procedures, the state should have the ability to say yes or no, whether we want to cover this or not. So I don't know if you want to say anything about that, or maybe I should mention the other one too. There was another Supreme Court decision involving the ACA and the Obamacare plans. And it's involving the task force, the U.S. Task Force on Prevention. And the case affirmed that this was okay, the way it's being done. A company sued the government because it claimed that these Obamacare plans now have to pay for these procedures that are mandated by this task force. And the procedures are just a wide scope of things, and they're sometimes political. That's what the employer was complaining about, that these were political decisions. One of the things that has to be covered under an Obamacare plan or any insurance plan is this thing called PrEP. It is a series of expensive drugs that are given to people who abuse drugs or engage in risky sex to prevent them from getting AIDS. And so there's big controversy over that. The employer didn't want to pay for that. They lost. All right. They lost the case. But what was interesting was Justice Thomas wrote the opposing viewpoint, and he pointed out that this task force is very political because, it's not, he said there are two conflicting clauses that allow how this task force is chosen. And the task force has always been around, but it's been an advisory body. Mm-hmm. And it basically says, we think these tests are helpful to the public and people should get them. But when Obamacare came along, Obamacare has a provision that says you have to include every test that this task force has to recommend. Now, this morning, it was interesting. Robert Kennedy, HHS Secretary Robert Kennedy, had canceled the first meeting of the U.S. task force. There is wide speculation that he's going to fire the entire board because they also mandate vaccines and contraception. I don't know how he's going to rule on that, but we have a pretty good idea how he might go on vaccines. And
well, it's kind of interesting from the standpoint. It is. I respect the board, but they have a impossible task, and part of that is political. For example, you probably recall back, I don't know, several years back, they changed the recommendations for when women should get a mammogram. I think it went from 45 to 40. Well, it wasn't that the cost per life year saved, you weren't buying back years of life at a bargain. You were buying back years of life at an extremely high cost by going from 45 to 40. But a very vocal, small segment of advocates, disease advocates, wanted that move, that recommendation moved to the lower age. So they kind of punted, so to speak, and said, well, if you feel like you're at high risk for breast cancer, you can now get a mammogram at age 40 versus 45. Well, that is just one small example of the plethora of recommendations the task force makes every year. And what they generally do, if you dig down into the methodology, they're looking at a benchmark cost per life year saved. You could mandate mammograms and colonoscopies every year beginning at age 5, and it would be extremely expensive, and the number of people saved would be so small that you'd be buying years of life at like $1 billion each. Well, that is not an affordable amount of money. That's not efficient. So the task force is essentially supposed to be politically neutral and pick the low-hanging fruit first and so on. But there's all this political pressure, by disease advocates to expand definitions because of Obamacare does make it supposedly free. Right. Another example of one of the free services is I could go to my doctor and I could ask for a free wellness visit under Obamacare. Well, I've talked to people that have done that, and they make the mistake of they call their doctor, oh, I want a physical. They go and they get a physical, they get a blood test, and they get a bill. And they're like, wait a minute, what do you mean? This is free Obamacare stuff. No, it doesn't give you a free physical. It gives you a free wellness exam. And what that wellness exam entails is sort of up to the doctor to some degree. And it does have overlap, the physical, but if you want a blood draw, well, that's not covered. If you even mention to your doctor, oh, I've had this certain symptom, and so your doctor checks it, well, that ceases to be preventive and becomes diagnostic, and so you suddenly have a bill. So there's all this ridiculous red tape involved that really turns a lot of the recommendations, and under Obamacare, that is, that turns them into a political football about, okay, what can we get Obamacare to cover? Because I would like more revenue to my segment of the economy that covers that, like colonoscopies, for example, or mammograms or what have you.
Well, exactly. And people cannot value these things if they're mandated to be covered. There's no individual input into it, and people are going to use these things because they're free. Colonoscopies are an invasive procedure, and there's mixed feelings about them because there is a risk to them. They're invasive, and, if the task force comes in and says, okay, we think Obamacare plans, all insurance plans should pay 100% of the bill for one of these tests every few years if you're a certain age. Well, most people are going to say, well, yippee, it's free. I might as well get it done. And that's a really bad way of making a healthcare decision. Everybody's different, and maybe not everybody needs that. And then, of course, you're right. There are a lot of politics that go into this body. Thomas had a real interesting, if you read his decision, he talked about the history of this. And he said that this task force is voluntary, right? So there are people who volunteer their time. They never were political until Obamacare became law. And then there's a provision in Obamacare that says now everything this task force says is going to carry the weight of law. It's going to have to be covered. So you can see right away people lining up at the door, wanting their test or their special interest covered, and recommended by this task force. And so Kennedy is now going to have the authority after the Supreme Court decision to appoint the people on this task force. And I'm sure he's going to put people in there who align with him. It's just the nature of the beast. But, again, it all comes down to the federal government micromanaging every single thing in healthcare. And that's why we spend so much money and we have so much waste, and it needs to stop. All right. The last thing I want to talk about, which is a blog post you put out, which was really good, on surprise bills. Now, the Surprise Bill Act was enacted in 2020, and it kind of leaves patients out of the loop. So, for people who aren't familiar with this, if you have a healthcare plan, you have to go for coverage, you have to go to a provider in your network. When you go to the hospital, a lot of times you don't know who's in your network. And there might be doctors there who are providing you care who are not in the network, and they're going to send you a separate bill. And people are floored when they receive these bills because they're not cheap. And so these are called surprise bills. There's also something called balanced billing, which I don't think this No Surprise Act deals with, but maybe you can explain that.
Yeah, it does deal with that.
Oh, okay. Okay.
Okay,
So,
what happens is, and this is controversial, but what happens is patients tend to choose a doctor based on, their network. You get the big book, you pull it, you go through, well, it's not really a book anymore, it's now a website. And if you're in the Blue Cross plan, you find the doctor that accepts Blue Cross. Hopefully it's the same doc. A lot of doctors are in all the major plans. So hopefully if your employer changes every year, you don't have to change doctors. But, but enrollees in health plans tend to want their doctors to be in their network because they enroll in some health plans just flat will not cover a non-network physician. But what happens is some doctors you cannot choose. You really cannot choose your anesthesiologist. They are mostly not really hired per se, but they are scheduled by a staffing firm that has a contract with the hospital. The same is true of a radiologist. The same is true of the physicians that are manning the emergency room. Oftentimes pathologists are similar, sometimes assistant physicians. The doctors behind the scenes that you do not choose yourself as a patient were really the ones that tended to have surprise bills. They had no incentive to be in a network because they couldn't be fired for not being in a network. Being in a network would not enhance their revenue, would actually reduce their revenue. So what happened in 2020, Congress debated several bills. And the bill that was passed, the No Surprises Act, essentially said if you go to an in-network hospital, and you are inadvertently treated by an out-of-network doctor, that doctor cannot send you a balanced bill. Because what happens is they'll send you a bill, or they'll send your insurance company a bill. The insurance company will say, "We're not going to pay this. We're going to pay, we'll pay 500."
Mm.
But the bill may be a list price of, say, 1,000. So the patient got the bill for 500. Well, under the No Surprises Act, that's called a balance bill. Under the No Surprises Act, if you in good faith tried to go to a in-network facility and had an out-of-network doctor treat you, the doctor and the health plan have to duke it out and figure out who owes what, how much. The patient cannot be held responsible. But the problem is of course, not being in a network, the physician or the practice group that owns them wants bills as high as possible. Insurance companies want, fees as low as possible. If they can't come to an agreement, they go to essentially an independent dispute resolution process, an arbitration. And what's happened is the arbitrators across the country are awarding fees that are all over the map. There's no consistency. You would think that there would be a semblance of a consistent fee for a given procedure. Well, it's not happening.
Yeah, right.
I think it's called baseball arbitration, where the health plan has an offer, the physician group has an offer. The arbitrator is supposed to assess what the right fee should be and pick one side or the other. And it varies depending on, who they're picked, which fees are awarded is very arbitrary. And a lot of health policy analysts are concerned, saying, well, this was supposed to lead to the closest we could come to a market outcome. But it really isn't. In fact, it did reduce costs that we can tell. So compared to out-of-network provider costs. So, and that is a problem, but unfortunately, we'll have to revisit that in the future to see if there is a fix for it. Maybe better training of arbitrators.
Yeah. I mean, I thought John Goodman, who is the co-publisher of Healthcare News and the Goodman Center, of course, Institute for where you post your blogs, he had a real interesting idea. He thinks that this is really, the onus is on the insurance plans, because it's false advertising when you're selling a plan and you're telling people they're covered. There is an expectation when you go to the hospital, you're going to be covered. And, like you said, there are all kinds of people, complicated networks. Some people are in it, some people aren't. And the healthcare plan is promising you coverage if you go to the network hospital. And he thinks these things should fall under the Fair Trade Act. I think that's what it's called. That there should be lawsuits regarding false advertising on these plans. And so it would really incentivize the health plans to do better diligence to make sure that they've got an anesthesiologist fee on board, or work out some sort of deal where that kind of care is going to be provided and there aren't going to be these extraneous bills because there's so many complications to who is in the network and who isn't. So I don't know. What you were referring in your blog post, wasn't there a study that found, well, you said that the resolutions were all over the map. They weren't necessarily ruling in favor of the doctor or the hospital. I mean, it was just super arbitrary.
Yeah, in some cases, you'd have one entity that would would favor providers like 90% of the time, and then you have other entities that would favor the health plan a substantial amount of time. And you would expect consistency. But I think a way to really expand upon John Goodman's idea would be to also engage with the hospital. I mean, the insurance company can't really control who's at that hospital, but the hospital can. And so if the insurance company signs a deal with the hospital, agrees on reimbursement rates, basically, it should be up to the hospital to talk to their medical staff and say, okay, if we have a deal with Blue Cross, for example, you need to negotiate with Blue Cross and arrive at a solution, or we're going to be in trouble.
Right.
Because under the Fair Trade Act, if the hospital is quote in the network, you would kind of assume that their employees and or their subcontractors would be too, but they aren't necessarily. And so you really need to put the screws to the hospital as well, because they are complicit in some of this.
Yeah.
And then you would have more leeway to put the screws to the insurance companies and say, okay, you need to sign up, if you have to have a network. There's what's called network adequacy regulations. And if you sign up that hospital, the hospital has to ensure that there are people at that hospital willing to care for patients that are in the same network the hospital is in.
Sure.
So
yeah, I would agree. Yeah, I kind of think there was an expectation in 2020 that if this bill passed, which it did, that everyone would be afraid of it and that they would work out reasonable rates, work out a system where they wouldn't have to go to arbitration, because that was
right.
a wild card. And so it would be better to resolve these issues before they ended up having to go into arbitration or whatever they call it. But apparently that hasn't happened. So,
well, and I talk about network affiliation. I mean, I don't necessarily mean that you have to force the doctor to be in the network, but at the very least, maybe have the doctor, the physician group say, here, negotiate fees. Okay, we're not in your network, but here are the fees we have worked out in advance with Blue Cross or Aetna or what have you, that you've agreed upon. And,
right.
It doesn't have to be, quote, in our network. It just has to, we have made a deal. We have an agreement. Here's what you will pay us for a given, service.
Yeah. Well, all kinds of big questions here, not going to be resolved here in our 45 minutes. So we've kind of run out of time. Be sure to check out Devin's writings at the Goodman Research Institute Healthcare blog. I'll include a link in the description of the podcast. And of course, healthcare news. We have just cover the latest in what's going on nationally and in various states in healthcare policy, and we present it from a free market perspective. So if both of those sources can make you a really good healthcare consumer. And the ones who I think really win this crazy, complicated race are the ones who are well educated. And so that's what we hope to do. And we encourage you to kind of check out those sources. And we appreciate your tuning in. And until the next time, stay safe, stay healthy, and we'll see you back here in a couple of weeks. Thanks, Devin.